Dear Facebook Pure Urology viewers, good evening one and all. As you all know, we are doing the surgical technique related to urology every other day. Today we are doing a rare topic, purely surgical technique related only. Otherwise, it is pediatric urology. As you all know, laparoscopy is equally applicable to pediatric population also in urology. Let it be right from the nephrectomy, pyeloplasty, which is more common in pediatric children, let it be ureteric reimplantation, let it be reflux detussorrhaphy, let it be transplant also. All these require special skill because the abdomen total volume is less, the carbon dioxide retaining capacity of the abdomen with high pressure is less, and the space to put the ports to act is very less. More so, in less than 5 years, we all combine children as one, which is not correct. 12 years old child versus 2 to 3 years old child, there is a lot of difference. 12-year almost behave like adult, whereas 1 year, 2 year children, not only the port placement, but the inside movements, bowel distension, these are all the things which are difficult. Because I also do a bit of pediatric laparoscopy, I know very difficult situations where you may not be able to proceed. In this extension, the robotic technology is used nowadays in all surgeries, especially where reconstructive urology is used. The people who have not used robotic, it is difficult to imagine in children. For those who are using also, the cases will be very less because the number of cases available in pediatric population is less. Recently, I came to know that Dr. Arvind Ganpule sir is doing pediatric surgery with robotic technology. That is very good because in an entire international, when we go through the articles and search the literature, pediatric robotic surgery articles are less. Cardiovascular are there, even ophthalmology is there, but pediatric robotic urology is less seen. So let us listen from Dr. Arvind Ganpule sir, what are the ports, what are the instruments, how they manipulate, and what are the technical difficulties. In fact, he has chosen the topic correctly. What are the dilemmas, the problems of this pediatric robotic laparoscopy. So Dr. Arvind Ganpule sir, thank you for accepting the invitation. Good evening, sir.
Good evening. Good evening.
Sir, first of all, I just wanted to take brief details about your career. Many of the people might be not knowing the post MCH career and MS career. Let us talk briefly for a few minutes. You are MBBS from which place, sir?
I did my MBBS from Kolhapur, that is the southernmost district of Maharashtra.
Maharashtra, Kolhapur.
Yeah. After that, I did my post graduation, that is MS from Solapur. That is at the Tri Junction. That city is at
yeah, sir. Solapur I know very well because my brother stays there.
Yes.
And Solapur is also from Maharashtra. You are from Maharashtra, sir?
Yes, I am from Maharashtra. So after that, since 2001, I came to Nadiad. I first did my DNB in Nadiad. Actually, in fact, before getting into the DNB program, I did 1 year of research at that time. Those of you who might not be knowing, actually, the community-based study, the natural history of urinary tract symptoms. So I was in charge of that particular study. So 1 year I was in that research, and then I got into the DNB program. So in 2006, yes.
Okay, sir. In MS, who was your influential teachers who have influenced in surgical career to you? Technique, knowledge, paper writing, academics, sincerity.
I feel that my postgraduate teacher was Dr. D.R. Kulkarni, and he was a pediatric surgeon. So I used to see a lot of PO fistulas at that time. Actually, our center was one of the centers where we used to do surgeries on infants for PO fistula, newborns rather than infants. And of course, Dr. Sachin Jamma was there, who actually influenced me on the importance of publishing and writing. So that was actually the start of journey. So my first publication was in the year 2001. That was in the Bombay Hospital Journal at that time.
Okay. So even before joining Nadiad?
Yes, before joining Nadiad, I had got 2 or 3 publications during my MS.
When did you join your DNB in Nadiad, sir?
In 2002. In 2000,
2002.
since 2002, I am there in Nadia.
Okay. You after finishing, you continued in Nadia.
So till 2006, I did my DNB, the DNB training, and then I passed in 2006. And from 2007 and 8, I did the endourology fellowship under Dr. Mahesh Desai, who is my mentor
Okay.
as far as urology is concerned.
Yeah, yeah,
And then from 2008 onwards, I'm here. 2010, we got the robot in Nadiad. So since
yeah,
2010, I'm involved in the program since we had got the SI. Now we have
yeah.
upgraded to the fourth generation robot.
XI.
We have got the X, not the XI. We have got the X. That is the hybrid model.
Okay. So now, when you shifted from laparoscopic training to the juniors laparoscopic surgery to robotic, what was the initial biggest advantage you have seen? What was the disadvantage you have noticed?
I feel as far as if I may say so, the terminology MIS, that is the minimally invasive surgery, which includes both laparoscopy and robotic. The way the surgeon thinks, the way the surgeon looks at a particular thing, the surgical anatomy, that is a bit different from the open surgical counterpart. So that is point number one. Maybe that doesn't answer the question that you have asked, but to answer your question that you have asked, that how does laparoscopy help for a robotic surgeon? I'm a true believer of that particular concept that if you want to do a robotic surgery, you have to first become a good laparoscopic surgeon. So during my MS days, I used to be told that if they used to say that a laparoscopic surgery stands on the shoulders of open surgery. So
Yeah,
I feel that robotic surgery stands on the shoulders of laparoscopic surgery. You just imagine a situation wherein you are just unable to place the ports laparoscopically. You don't have the principles of how to place a port. Or maybe you have completed an robotic radical prostatectomy. And just for the last part, the anastomosis part is remaining, and then the robot just shuts down. So it would be very unfair for the patient that you just convert it into an open surgery. My advice would be
yeah.
that always you should be at least know the basics of laparoscopy before you graduate on to become an robotic surgeon.
Sir, one more doubt. So many robotic surgeries I have seen before we go to the talk. I have a doubt in laparoscopy. We get something like a bleeding from the renal artery, renal vein, IVC, gonadal vein, corner veins tearing. All these things are very difficult to manage. Generally, generally the surgeon will put immediately the suction gauge piece or the laparoscopic instrument to stop it in fraction of seconds. What happens a console person realizes that he made a nick in the IVC and sudden bleeding happens. He cannot act immediately the way like laparoscopy is my feeling. Second thing, the assistant should be equally intelligent to act with your brain and your robotic technology. So is it not difficult so that you have to undergo open than converting into lap? Are you mentally prepared every case for lap conversion? And the ports are too medial, and by the time you put your pressure on the bleeder particularly, it may be it may be torrential bleeding. So many surgeries the world is doing. This is never addressed.
See, there is a paper in the Indian Journal of Urology wherein they have emphasized on the importance of the bedside assistant in any robotic surgery. I
Sir,
must say that the key person for any robotic surgery is the bedside assistant. I think the surgeon is the most privileged, robotic surgeon is the most privileged robotic surgeon if he has got an experienced laparoscopic surgeon as a bedside assistant. In that way, at Nadiad, we are very, I must say, we are blessed that most of our surgeries are being assisted on the bedside by our fellows who themselves are doing laparoscopy. So they can tide over the crisis. But if you go
yeah,
across the Atlantic and go to the US, you will see that most of the robotic surgeries are assisted on the bedside by somebody which is called as the physician assistants. So those physician assistants are also equally, I must say, they are also equally skilled in this particular concept. So yes, it actually rattles the nerves sometimes whenever you have gotten bleeding, but there are ways in which you can control it robotically as well, as the
as well.
inherent specifications on the robotic platform help you to maintain the pressure on the bleeder and so on and so forth. We can discuss it as we go along in the talk.
Yes, sir. Yes, sir. Sir, today for the viewers, we are discussing on robotic surgeries in infants and toddlers, challenges, dilemmas, and solutions. The speaker is Dr. Arvind Ganpule, sir. Briefly, I will go through his career. Definitely, it will be very interesting. He is a Vice Chairman, Department of Urology and Chief Division of Laparoscopy and Robotic Surgery at Muljubai Patel Urological Hospital, Nadiad. Those who are listening across other than India, MPUH is considered as one of the most academic best institute in urology in India. He has innovated a novel low-cost retrieval bag in laparoscopy known as the Nadiad bag. He was involved with the team of MPUH Nadiad India in developing the microperk system with poly-diagnosed GmbH. He has three patents filed with Indian Patent Office. That's great. He has 178 PubMed Index publications to his credit to repute peer-reviewed national and international journal. In addition, he authored 26 book chapters and edited 6 books. He was a lead investigator in the largest epidemiological study in India, investigating the natural history of BPH in Western India. He is a recipient of the prestigious MIUC Scholarship of the Urology Society of India. He was named as AUA USA Scholar for the year 2012. He is currently the convener of the USA Endourology Cell. His area of special interest include advanced robotic surgery such as pediatric robotic surgery, RAKT and endourology. He has authored chapters in Campbell Urology, Smith Textbook of Endourology, and Hinman's Atlas of Urology. Last one is really interesting, great. Highly appreciated, sir. And I thank once again for giving the opportunity. Over to you, sir.
Thank you very much, Dr. Chandramohan. I must say that I am indeed privileged and honored to be here on this platform, which I must say is an trailblazer in this particular field. And kudos to Dr. Chandramohan for initiating this particular endeavor.
Thank you, sir.
And again, Dr. Chandramohan, thank you for your kind words. I've been charged with the duty of talking something about robotics in infants and toddlers. I'll be talking on the challenges, dilemmas, and solutions. We all have gotten habit to Google everything whenever we are given a talk. So I also, according to the same habit, Googled what do we mean by toddler. So a toddler is a child who has just begun to walk, and a newborn is a newborn who is just within few months and who has arrived in this world just a few months back. So we'll be talking about robotic surgery in this particular small group of patients. And we will be very specific as to what are the challenges, what are the problems in port placement, patient positioning, what are the different indications, what are the problems that are associated with the robotic technology as of now, and finally, a few concluding remarks. Uh, Dr. Chandramohan has rightly raised the particular thing about learning curve and how I got into the field of urology. But I would like to dwell a little bit on my learning curve for robotic surgery in infants and toddlers. So everything started back in the year 2012. And in the year 2012, I was visiting the US as an Chakravarti USI fellow at the University of Chicago in the Department of Pediatric Urology. And this was the hospital where I was actually being trained under Dr. Mohan Gundeti. I feel Dr. Mohan Gundeti doesn't require an introduction. He's considered to be the leader and think tank in robotic pediatric surgery. And then we have got our own Dr. Venkat Sripati, who is a pediatric urologist in Chennai. And then you see Dr. Eri Shalayo, who is the professor and chair at the University of Chicago. So my journey for about robotic pediatric surgery started with this after the robot arrived in Nadiad in the year 2010. But as they say that a doctor should taste his own medicine. So my tryst with pediatric robotic surgery was associated with my own illness, and I was diagnosed to be having an ureteric colic when I was in the US, a 7 mm lower ureteric stone, and I must say the role and the host changed. So I initially was a student with Dr. Gundeti. Then Dr. Gundeti became my treating doctor. He got the stone out, and then he again became my mentor. Similarly, my role also changed from becoming a student in robotic pediatric surgery to being a patient and back to being a student. So this is an interesting anecdote which I thought I should share with you before going ahead. Apart from Dr. Mohan Gundeti, I feel that this particular gentleman, and it would be interesting how many of you can identify this particular person. He is Dr. Craig Peters, the author, the editor of Campbell's Urology. I was fortunate to assist him as a bedside assistant when he was visiting Nadiad in 2011, and I had assisted him in an robotic surgery in an 3.5 years old child, in which he did an pediatric in a 3.5 years old child, and later on in a child he was just 4 kgs in weight, way back in 2011. And then I also assisted him in a few of his ureteric reimplantation. So I feel that these two gentlemen have got a large amount of impact on the way we understand robotic pediatric surgery. But let's come to the moot point. You ask a question to any pediatric surgeon, or for that purpose, any urologist, that should we be doing laparoscopy? For that, leave aside robotic surgery, should we be doing laparoscopy in extremely small children? And I can guarantee you that 80% of the people will say that there is no advantage in children. The incision I use, mean that surgeon who is operating uses, is of the same size of the combined trocar sides, and the infant recovers in a day. They will go on further and say that the small incision has got very minimal pain, and the child goes home maybe the next day or the day after. But my counter question to all of them is, can you really assess if an infant is having pain? Does the infant tell you that the infant is having pain? Does the child really want to go home the next day? If no, then why is it considered as a parameter to assess the same thing? Further, the excuses that can be given of not doing an laparoscopic surgery is that why to go have the trouble to use robotics or laparoscopy in small children? They recover from open surgery so quickly. Why add to the cost? Most of these operations can be performed through a minimal small incision, 2 centimeter incision. It is too costly. No proof that it is better. I will wait until the instruments are smaller and better, and the excuses will go on and on. But one thing that we have to understand, that MIS, that is minimally invasive surgery, is a conundrum. It is not I must say, a snapshot. One has to remember certain points in this. Simply reducing the number of stitches is not the goal of minimally invasive surgery. Surgical morbidity is a complex combination of tissue trauma, metabolic changes, inflammatory effects, and the patient perception. Each and everything is very important. Tissue trauma, metabolic changes, inflammatory effects, and ultimately the patient perception. And in this subgroup of patient, it is the parent's perception also. So we should not just push it under the carpet that MIS is of no use in infants and toddlers. Let's see how. The common application of robot in pediatric urology, we all know, is robotic pyeloplasties, robotic ureteric reimplantation, robotic bladder diverticulectomies. And then we go on to I must say, the next level, robotic appendicovasectomies, robotic augmentation cystoplasties, and robotic heminephrectomies. But I must say that out of these, if you go into the last three, that is the appendicovasectomies, augmentation cystoplasties, and heminephrectomies, there are a very few papers, and I must say that almost no papers, if you consider ileocystoplasties or metrophen of appendicovasectomies done in infants and toddlers. We are just talking about this small subgroup of infants and toddlers. So the commonest indications in infants and toddlers are, I must say, robotic pyeloplasties, when indicated, robotic ureteric reimplantation, and some unusual procedures such as robotic diverticulectomies. I will be talking on the principles of robotic surgery in infants, what are the individual procedures and few technical details, issues related to the robotics in pediatrics, and finally, a few last words. So when we are going to talk about the technique, we'll be talking on the patient positioning, trocar positioning, individual cases, issues for robotic instrumentation. So let's go one by one. What are the points which are very specific to patient positioning and trocar positioning as far as infants are concerned? So now there will be exactly 6 to 7 slides after this, and most of the content that I have taken, I must acknowledge this particular paper in which they are extremely nicely demonstrated or written down what are the points that are very intricate to infants and toddlers as far as robotics are concerned. So the physiological considerations are twofold. I must say that Dr. Chandramohan has already addressed 2 of them in his prelude. So as far as the respiratory problems that are considered, that should be considered in infants and toddlers, are that the peritoneum of infants is relatively larger and better perfused. So the absorption of CO2 is also proportionally more. And that is the very reason that one has to have an eye on the EtCO2, particularly when operating on these small kids. Unlike in adults, all of you will agree, those who are operating, that the level of CO2 tends to plateau during surgery in adults. However, this doesn't happen in infants. And hence you will see that these small kids very fast tend to desaturate when the pneumoperitoneal pressures are very high. This is something very important when you want to keep the pneumoperitoneal pressures at an optimal level when you are going to operate on these kids. Next consideration are the cardiovascular consideration. Higher the pressures that you keep, say if the pressures go beyond 10, there will be decreased venous return, decreased right ventricular cardiac output, and hence the cardiac input, and hence the cardiac output will also go down. So this is something that you have to remember when you are going to operate on patients who are just 6 to 36 months in age. The next important thing is that increased abdominal pressure, these kids have got a tendency to cause catecholamine release and causes increased mean arterial pressure. This is also something very important, apart from the tendency to cause bradycardia due to robust vagal refluxes. Apart from this, most of you who will operate, you will see that if you keep the pressures around 8 in infants or children, 88% of them will have either oliguria or anuria intraoperatively. But let me give you an reassurance that most of the times this oliguria oblique anuria will be reversible with a maximum effect seen approximately 5 hours after desublation. A few anesthesia related considerations when you are going to operate on infants and kids. Absolutely know that there should be no nitric oxide. It causes bowel distension and it will obscure your vision. You will not be able to see whatever you are going to see because the abdomen is small. You will not see anything. The bowel will start coming in the way. Of course, this is not rocket science, that never laryngeal mask, always intubation with endotracheal tube. One can realize a small kid lying on the operating table, and the anesthesia circuit is there at the far end of the table. So the anesthetist should know this particular thing, that if there is an emergency, the patient is at least 2 feet away beneath the robot whenever you are going to operate on this kid. So this is something that the anesthetist should be aware of every time whenever he is going to operate, that how he is going to dedock, how the surgeon is going to dedock, and in case of an emergency, how they are going to tide over the crisis. And finally, post-operative management is also very important. Just because the kids cannot tell you, it doesn't mean that the anesthesia management, the pain management should be suboptimal. So aerosolized bupivacaine can be used to decrease the length of hospitalization in the small kids. And of course, the pain. Now, coming to a few technical details, those of you who are uninitiated for the robot, there is a concept of virtual center. Whenever you are using a robotic platform in anybody, it may be an adult or an infant. So, what is a virtual center? You'll be seeing this thing in the coming few slides. That if you see the trocar of the robot, the outer trocar, the outer sheath of the robotic trocar, you will see that there is a black band on the robotic sheath, and that is something which is called as the robotic center. Sorry, the virtual center. So the system uses the virtual center to allow a point on the cannula holding the working instruments to be motionless. So this white band will be motionless, but the rest of the trocar moves. So you'll imagine the amount of traction on the abdominal wall is naturally less in robotic surgery because the whole instruments are going to move around this fixed point in space. The whole instrument, as in laparoscopy, is not going to move. So in that way, there will be very minimal traction on the abdominal wall, and hence most of the times the patients robotically have got lesser pain in the postoperative period as compared to the laparoscopic thing, just because of this concept of the virtual center. And this helps in pediatric patients, but it also is counterproductive in a way which I'll be showing in the next few slides. And how it is counterproductive, you can see in this slide. So what you are seeing on the top part of the slide is an adult scenario, and what we are seeing on the bottom is what you see in infants. So you see there is a lot of space inside the abdominal wall whenever you are operating on in an adult. So minimal movement inside the abdominal wall will not lead to clashing of the instruments extracorporeally. Why? Because the virtual center is exactly at the peritoneum. Now what will happen in an infant? Naturally, the space inside the abdomen is very small. So the virtual center is lying over here. So excess amount of instrument is lying outside the abdominal wall, extracorporeally. So as a result, minimal movement inside the abdomen will cause banging or clashing of the instruments outside. So this is something that one has to realize. Unfortunately, the company is not, the Intuitive Surgicals is not on board on this. So if you see that they market the instruments as 5 instruments, they will not market it as a pediatric instrument. So as a result, the instruments are ill-conceived, not properly made, and as a result, this is a challenge when you are going to operate in any small kids as with the robotic platform. The other mechanical considerations that you should consider that, of course, you must realize that there is a limited space in infants, and hence the movement is also limited. And once the robot is docked, this is an absolute no, that once the robot is docked, you cannot move the robot unless you dedock the robot, and then you can move it. Otherwise, there might be a catastrophe intraoperatively if you start moving the robot with the instruments armed inside the robotic trocar. And I already discussed the last point, that is the positioning of the virtual center. It is of pivotal or key importance. As far as the operative considerations are considered, let me take you one by one through all of them. The procedural steps are identical, even though if you operate in an older kid or otherwise. The movements of the robotic arm should be precise and controlled. For this, you should understand, if you go to the console of the robot, there will be three modes in which you can operate. One is normal, one is fine, and one is ultra fine. So in ultra fine, it is called as 1:5 movement. So say 5 centimeter movement of the masters in the console will lead to just 1 centimeter movement inside the abdomen. So always when you are going to operate in an pediatric in an infant, it should be in an ultra fine mode. The instrument exchanges must be done cautiously, and it should be done slowly under direct vision. There should be an ongoing and unambiguous communication between the team and the members, that is the bedside assistant. And most important, that is that the passing of needles. And Dr. Chandramohan will also agree with me that losing a needle inside the abdomen is like a nightmare in any minimally invasive surgery. So
Yes, sir.
this is very likely to happen, particularly when you have got an uninitiated assistant, an inexperienced assistant, and small trocars and small ports. It is quite possible while passing the needle inside, you can just lose the needle inside the abdomen.
Yeah.
So that is very important. There are a few variations in which you should dock the robot, particularly for a pyeloplasty. You can see that the patient is not exactly at 90 degrees, and the straps are also arranged in such a way, like in in laparoscopy, the straps will come in this way. But here we are going to arrange it in this way because the robotic arm is going to come in the way if you apply the same in this way. So that is point number one. It is needless to say that always make sure that the face of the child is covered in this way so that the robotic arms do not inadvertently clash with the face of the infant, and all the pressure points should be securely strapped and padded. So there is one more important thing, or I must say, which is very unique to infants and toddlers. And the thing is this: that as the space inside the abdomen is very small, it is very possible that the trocars get spontaneously extruded from the abdominal wall in infants. So what is the way in which you can make sure that the trocars are secured to the abdominal wall and they don't come out? So this is something which Dr. Craig Peters described, and he said that it is called as the RoboFix. You see that we are using the steri strips which we use for dressing, and then use a box stitch. The box stitch I'll be showing in the video. The box stitch is passed through the abdomen, and then it comes out. It is secured to the trocar, and then the whole thing is secured with the help of the steri strips. So in this way, the trocars, it's very unlikely that the trocars will slip out while doing the surgery. There is one more concept which again can be actually replicated in laparoscopy, is that this has not been published anywhere, but I always personally feel that the distance from the xiphoid to the umbilicus is like a predictor which can dictate the difficulty in which a surgeon is going to have while placing the trocars and doing the surgery on the kidney. So you see that in most of the cases, the xiphoid to the umbilical distance is always very minimal. So that is the reason that as far as possible, try to space the ports away from each other as much as possible when you are going to operate in the infants. Now we come to the core question that we want to answer, is that is robot assisted pyeloplasty superior to conventional pyeloplasty in this subgroup of patients, that is infants and toddlers? So to answer this question, I must show you this video. This is this 3 kg child, and you can see the intricate differences in which we place the port. In all the cases, the access is through the umbilicus, because in this way we'll be able to place the 10 camera port through the umbilicus. And this is something which is called as the box stitch, which I showed in the RoboFix slide. This is the box stitch, and that stitch is then secured with the help of the steri strips. Now, after doing this thing, you can decide whether you want to go transmesenteric or you want to reflect the bowel, particularly on the left side, not on the right side. Here, as you can see, that is an good extrarenal pelvis, and hence that is the reason that it's not necessary that you should go ahead by reflecting the bowel. Now let's come to the details of the procedure. It almost mimics the open surgery. Let me remind you that this is a 3 kg child, a 3-month-old female. It's an extrarenal pelvis, so we are marking the point where we are going to do the pilotomy, and this is something which is called as the heel stitch. It comes from the abdominal wall, goes through the anterior wall of the pelvis, and then it goes back through the same point back into the exterior on the extracorporeal part. It helps us in lifting up the pelvis and identifying which is the most dependent part. Now, this would be the most dependent part. And again, let me remind you that without placing any of the heat stitches, or I must say stay suture, just one suture that is passed through the abdominal wall is helping you in orienting the whole thing. It is helping us in identifying which is the most dependent part of the pelvis which we are going to anastomose. It is also helping us in holding the ureter, because the redundant part of the pelvis is held, like I must say, like a handle. And now comes the most challenging part. Now, hardly this might be an 2 French ureter, and spatulation would be really challenging, but you see the dexterity and precision that the robot is offering is helping us in doing a lateral spatulation. As they say, the mnemonic is SL, that is lateral spatulation. And identifying the vertical longitudinal folds will help you in identifying. You see the vertical longitudinal folds, that only shows you that the spatulation is adequate. Let me point out that throughout this video, you'll see that the robot offers an unique opportunity of not holding that part of the tissue which you are going to do the anastomosis. So it is an absolute no-touch technique. The knot lies outside. We have gone from outside in the ureter, inside out into the most dependent part of the pelvis. And the Maryland, you see the Maryland is helping us in making the proper throws. The very common question that is asked is that which layer in an pyeloplasty are going to suture first, whether it's going to be the medial layer first or the lateral layer first. I think the answer is made easy. A difficult question is made easy with an easy answer robotically. Whichever way is easier and proper ergonomically aligned, the robot offers you an opportunity to do the same. But one thing is there, that the antegrade stent, that is the choice that we always do. The antegrade stent is always placed after one layer is completed. So you see that throughout the procedure, we are not holding any part of the tissue that we are going to anastomose, and either the thread is being held for aligning the whole thing, and then of course the 360-degree movement of the robot is offering us an unprecedented opportunity to do the suturing. So this layer is completed now, and now comes the part of placing the antegrade stent. So you can imagine that being an 3 months old female child, we have to use an angiocath with a small stent, which is an 0.3 French stent, which is a 3 French stent passed over a 0.314 wire. Of course, the bladder catheter is clamped, and through an angiocath, the stent is passed inside, and then free efflux of fluid that would be coming through the side holes would ensure that the stent is there in the proper position. So what I would like to highlight here is that the robotic instruments will help you in proper dexterity of the whole thing and help you in mimicking exactly the same way we do in pyeloplasty in the adults. Coming to the question as to which is better, whether the robot is better or the laparoscopy is better. So I would like to give a disclaimer here is that what is more important whenever we are going to consider this subgroup is not the age of the patient, it is the weight of the patient. Sometimes you will find a 10 years old child, but who is hardly 7 or 8 kgs in weight. Similarly, it might be the other way around also, that it might be a younger kid, but his weight is more. So lesser the weight, more challenging the procedure will be. So in this study, what we decided that we compared the outcomes of robotic pyeloplasty versus conventional laparoscopic pyeloplasty in children who were less than 20 kgs of weight, and we tried to find out what is the outcome. So as you can see in the last line, we had failures in both the cases. Interestingly, this is the importance of having a laparoscopic training. That in one of the case, the robot just stopped functioning. So we completed the case laparoscopically, and if you see the operating time, significantly the operating time was more in laparoscopic procedure. Otherwise, the hospital stay was also more or less the same. This was not statistically significant.
Sir, when
So
you
the one
convert the
important
robotic to,
amendment
sorry,
in this
sir.
case would be that there should be a use of an 8 instruments even in toddler, not the 5 instruments. I'll be talking on this a little bit detail later on. Use of box stitch to prevent extrusion of the ports. Use a 10 camera port in all, not a 5 camera. And the use of RoboFix is very important. Coming to the next set of procedures that we can do robotically, that is robotic ureteral reconstruction. So here was an 10 months old kid who was a full term normal delivery, not normal delivery, cesarean section, normal milestones, had recurrent urinary tract infection which were culture proven, and he was circumcised, and we at the time of operating he was 7 kgs of weight. On imaging, you can see that he's having an obstructed megaureter with a small segment narrowing over there. Now, these were the early days of our robotic program, and hence we decided to do an RGP just to identify how long is the stricture and so on and so forth. This may be debatable; it may not be necessary every time, but at that point in time, we thought that placing an stent at the beginning would be more useful. Hence, we did a retrograde pyelogram. You see that it was an obstructed megaureter. Following that, we placed a stent. And then as I showed in the pyloplasty part, this was in 7 kg kit, lithotomy position, same ports as you would place in an laparoscopic approach. And this is the box stitch that I was talking about, which is fixed with the help of an tegaderm. And the port goes exactly in between the stitch, and then the Sterifix will fix the port on the exterior. This was the old version, that is the SI. I must say that the newer version, that is the fourth generation robots, would be more useful in this subgroup of patient, because the X or the XI have got slimmer arms. The instruments are also very thin. So the extracorporeal clashing will be also less when you are going to do these procedures in these small patients. So coming back to the procedure, the first step that you have to do is identify all the structures inside. You can see the sigmoid. You can identify the impression of the bladder using the impression of the balloon catheter. The ureter is dilated on this side, so it was very easy to identify. As well as being a male child, you could see the vas as well. Now the question comes here as to whether we are going to do a tapering, and you can very well see the narrowing over here. The narrowing was seen. You can see the narrowing over here. So this paper is actually from PGI Chandigarh, and Dr. Chandramohan must be knowing about this. That they say that the tapering is done best before disconnecting the ureter from the UBJ, because that gives you an proper angle to do the tapering, as well as the suturing becomes more easier when the ureter is still attached to the bladder. So we followed the same thing, and this was the part which actually we disconnected later on, and the excess ureter was excised, and then tapering was done. And the suture material that we are using here is an 50 Vicryl, and the tapering will proceed right till the part that the excision was done. So I must say that this is the part of the surgery wherein actually the robot would offer a better advantage. The plan for the procedure later on was that we actually initially decided that we will completely do a new a new ureteric reimplantation at a new place. So we did the same thing as you will see in the video that follows, as well as we decided to do the detrosography. But before doing that, we also closed the ureter in 2 layers. As you can see, then not in 2 layers, but the peritoneum was covered over the excess tapering that you can see over here. The next step was to create an detrusor tunnel. So again, this almost mimics that we what we do in an laparoscopic approach. The only advantage that the robot offers is that the versatility of the instruments. You see that throughout this procedure, we are using the Maryland, which actually helps in the suturing, and that helps us in avoiding using an additional instrument. And in effect, it will also help us in saving on the cost. Secondly, you could see that we are also using the hook, because the hook will also do the same job what an hook will do in laparoscopic milieu. By the time I was talking, you can see that a neomeatus was created over here and a reimplantation is done. And what we are seeing is part of the detrusography. And you can see the mucosa over here, and the detrusor tunnel is being created, and the whole ureter would be, I must say, transposed like so, so that a good detrusor backing is given to the neo ureterocyclostomy. So most of the principles that we follow in open surgery are followed here, even when we are going to do the robotic platform. The approach will not change the principles. So apart from now, this is the last part of the retrosoraphy, and the ureteric reimplantation is completed, as you can see in this picture. Apart from this, there are a few other indications as well, which can be easily done. Like here, we reported a case wherein robot-assisted laparoscopic bladder diverticulectomy was done in a 7-year-old kid. A few important points. This was the diverticulum. The patient had got recurrent UTI, which was not settling down. So these are the few snapshots. But the important thing is that always try to see what are the important structures whenever you want to do. Like you have to see where the ureter is. For that, a stent is important. For the identification of the diverticulum, the movement of the Foley bulb is important. The methylene blue is also important, apart from the suprapubic catheter. I come to the last part of my talk, wherein I would address a few issues which are currently there with the current pediatric robotic instruments. The only issue to my mind is that the current 5mm, we call them pediatric robotic instruments, but the company never calls them pediatric instruments. They call them 5mm robotic instruments. I must say, to say the least, is that they are ill-designed and ill-developed. Actually, with the current available instruments, this particular branch of robotic surgery is not going to progress because they are absolutely ill-developed and ill-designed. I will tell you why. Because whenever you consider these 5mm instruments, we have got very limited choice. You need to choose from scissors. Most of the times, if you take these scissors, these are 8mm scissors, and this is a 5mm scissor. 8mm are used in adults. You see that there is no cautery setting in 5mm. So you'll have to use a scissor which doesn't have any electrosurgical unit. You'll have to use a hook. The hook is extra long. So because why this happens, because these 5mm instruments are actually used for transaxillary thyroidectomy, or you can call something which is called as TORS. So these are 5mm instruments. That's why we say that they're pediatric instruments, but their purpose is actually for TORS or for maybe a transaxillary thyroidectomy. But they are ill suited for the purpose that we are using them as of now. To take this 5mm instruments, which this is a 5mm instrument, this part is intracorporeal, and sorry, this is an 8mm instrument which is intracorporeal. This is a 5mm pediatric one. So you see that this gooseneck, which is an extra long part, this amount of part, this is ill spaced. So in effect, what happens that majority part of the instrument will remain inside the abdomen, in which the working space inside the abdomen is already limited, and further having such instrument will further limit the movement of the instrument. So this video will demonstrate that how an instrument which is actually ill-designed will actually be counterproductive whenever you actually want to operate. So again, in small kid, you see the amount of instrument that is inside. You can see here the amount of instrument that is inside, which would actually make the surgery more difficult. So any movement of the surgical instruments is absolutely restricted because of this. Going a little bit further on the problems with the instrumentation is that you can see that the currently available instruments have got trocars and obturators which are ill designed. So why I'm bringing this point forth is because the company needs to work on these particular points so as to give a better experience to the surgeon as well as the patients. A few points which are specific to the procedure and which we already discussed is that most of the times the dock is difficult. Why? Because just because of the fact that the patient is small, And hence you have to use these additional techniques of using these steady strips. You have to use these additional box stitches to make sure that that the sutures are fixed properly to the trocars and the trocars don't come out intraoperatively. And this is the RoboFix that I was talking about. So finally, one needs to understand that robot is just a tool. What is more important is the man behind the tool. So this is something that you have to realize when you are going to do something which is for reconstruction. Finally, my last word or my last take on this particular topic is that the major hindrance in the development of pediatric robotic is that there are differences in practices in which pediatric urology is there compared to adult urology. This is one way, this is one of the reasons why actually the development of this field is very tardy and very slow. Because suppose if I say that I like to do pyeloplasty in an infant using the robotic platform, I'm sure that there will be a lot of difference of opinion within my friends itself. So in that way, a proper randomized study in between colleagues or peers is not possible. Lastly, as I just mentioned, that a lot is desired from the instruments. Unless the instruments improve, there will be no phase of evolution in this particular field. Finally, coming to the part of the outcomes, I feel that there are two difficulties in assessing the outcomes in this small group of patients, that is infants and toddlers. One is the costing, because every time you talk about robotics in infants and toddlers, the thing about cost will come. And finally, the thing about parental perception. That is, people will say that the patient doesn't feel pain and all those things. Let's address these two issues. So the cost assessment in laparoscopy is always inherently flawed. You see any study in surgical literature which assesses the cost, the study design is not very perfect because you don't know whether you want to include the capital expenditure, the running expenditure. So the costing of that particular study, the costing analysis is always flawed. So the economic impact of reducing pediatric surgical morbidity, considering the cost factor, is trivial, and this cannot be always considered as a benchmark. And finally, the next point is about parental perception. I must say that this is a very abstract thing to assess. It is difficult to measure or understand its value. That is the value of parental perception of morbidity of their kid. Always, any parent would always like to have a child which would have such a small scar, and the child is ready to go home in the next 2 days. I finally close my talk by showing this particular talk, or I must say, an interview for the Mercurial Dr. Shashi Tharoor. Once a British journalist asked Mr. Shashi Tharoor, why was it that the Indians missed the why is it that the Indians missed the Industrial Revolution bus in spite of the British providing the infrastructure during the British Raj? So let's see what Mr. Tharoor had got an answer to.
Audio.
So I must ask you that why should we miss the bus on the why should we miss the robotic bus? We should not miss the robotic bus, or get thrown under its wheels. This is very important, and how can we achieve this particular thing? I must say that the modern technology permits a joining of the basic principles of surgery with further minimization of morbidity. So technology will inevitably evolve. You accept it or you don't accept it. It is going to evolve. So we need to evolve and revolve around it. And that's the way in which we, the industry, as well as the patients, can go ahead in this particular field. Again, thank you very much, Dr. Chandramohan, for allowing me on this extremely well-conceived platform. And it's indeed an honor to be here. Thank you very much.
Thank you, sir. Thank you very much. Am I audible, sir?
Yes, yes, you are audible.
Yeah. Sir, it's an excellent talk. Actually, I thought very less people will join. 120 people have joined. Maybe because of your knowledge and ability to communicate what you wanted to crisply. I will ask quickly 5, 6 to 10 questions related to laparoscopy and robotic. Number one, uh, if you are keeping more than 3 ports, normally you teach so much about the angle distance in your laparoscopy. I heard from 2010, even still you are Johnson consultant for the laparoscopic suturing. You always say that there should be this many centimeters, this many things in between the ports. Is it possible to keep such distances in children? Is there any difference between laparoscopic ports, simple pyeloplasty I'm asking, with robotic ports?
Yeah, the concept of one third and two third that we always teach in laparoscopy doesn't hold true for robotic. The
Yes,
reason being the virtual center thing is that the whole instrument moves around that band. That is point
yeah,
number one. Number two, the human hand doesn't have that 360-degree of movement.
yes,
That is the second thing. And the third thing, as far as reconstruction is concerned, even in pyroclasty, we would like to have a good azimuth angle.
yes,
So the azimuth angle should be equal on both the sides of the camera port. So this
yes.
particular concept holds true even in robotic surgery, that the azimuth angle, as far as possible, should be equal on both the sides. The manipulation
Okay.
angle can become more narrow, but the azimuth angle should be equal. So that would be my answer to your question.
Yeah. Second question, because in robotic arms, the distal end is inside closely working to the area of interest. Do you think that less than 10 of Hg distension is sufficient, or you need more, or it is same like laparoscopy as far as pneumoperitoneal pressure is concerned?
I feel bad that it can be the same or even it can be the less. It can be less. Just because of, again, because of the fact, I feel that what robotic surgery, the gift of robotic surgery to the surgeons is the virtual center. The
Virtual
virtual
center.
center actually will help you in keeping the pressure slower than what you
Yeah.
do in laparoscopy.
Okay. So, in do you have any experience? Are you doing renal transplantation recipient robotically?
Yes, we are doing it. We have done 40 of them. We have got a follow-up of approximately 5 years. We are very choosy about them. We only do it in obese patients, and preferably whenever the patient has got an right kidney to be donated to an obese recipient, because we feel that that deep cavity and a small vein, the robotic platform would be better. We have done. I think what we want to ask is whether we have done it in infants or pediatric age group.
Yeah, yeah, definitely.
So we have not done it in infants and toddlers, definitely not. But we have done it in one 13 years old child. So
Okay.
as I told you, that age doesn't matter. What is the weight? The weight of of that particular kid was approximately 25 kgs or something. So that was okay for us. So we have done one in that particular age group. So if you say 13 as pediatric, yes, we have done one.
Okay. Basic question. In during laparoscopy, when you put the ports, if you want to reflect the colon or if you want to turn this side, too much tilting of the patient can be done along with the bed. Can it be done with robotic also?
You can do it with robotic, but the principle remains that you have to decide it beforehand. What would be the tilt? That is point number one. Point number two is that if you want to change the position intraoperatively, it is an absolute prerequisite that you should undock the robot first. You should undock the robot first and then change the position.
By undocking, the number of instrument usage will increase.
No, it will not
There will
increase.
be a number, not.
It will increase only if you shut off the system.
If you undock, any disadvantage in robot?
Not really, because many a times, like say nephrectomy, we are doing a case for say TCC, radical nephrectomy, and we want to remove the bladder cuff. So in the initial version, that is in the SI, we had to do double docking. That is once for the kidney and then once for the bladder. So at that time, we used to remove it and reposition it. As long as you don't close down the system, it will not come.
Yeah. In suturing, the large sutures versus small sutures. In laparoscopy, you only designed one or a Ganpule Nadiad needle holder, where the tip is very small for the small sutures. Does because laparoscopic robotic instruments are costly needle holder, can you hold a 50 as well as 20 with same dexterity, say without any problem?
Yes, actually, that is an excellent question, because we don't have that type of a needle holder in the robotic milieu. but definitely they call it as the diamond tip needle holder. It has got like a swan like tip. That particular needle holder has got a swan like tip. It doesn't exactly mimic the 3x5 prototype needle holder that you are talking about, but it helps the suturing better. Consider to answer that part of your question, wherein you say that are there any tips in which you can avoid breaking the suture while you are going to do the suturing robotically. In the pyloplasty video, you must have seen that the operating surgeon was using a technique which is called as the pulley technique. Actually, he was not holding the thread with the help of the robotic instruments at all. He was just pulling and giving traction to the thread using the help of the robotic needle holder. So that
Yeah,
is
I
the
have
way
seen that.
how you can actually overcome that particular problem.
And many of the times I have seen the about they in the prostatectomy. This may not be related to pediatric. They cut with the instrument itself like this. If they break like this, they break and remove it. Uh, any suture can be broken with like that.
Yeah, any suture can be broken, but there is one specific needle holder which is called as suture cut in the robotic thing, wherein the angle has got an scissor, and here is the
Caesar.
needle holder. So that is a specific needle holder which is called as a suture cut. But anyhow, any of the thread can be broken with the help of two robotic instruments.
Okay. Uh, regarding the magnification, do you think that when compared to the adult and children, I was seeing that 3 months baby magnification, it was very good, excellent. Do you think that in future, if you get smaller instruments, this magnification will be much more helpful in less than 1 year children when compared to laparoscopy?
I feel, yeah, the magnification part is definitely an added advantage to the robot.
No, more so advantage in children. If, have you noticed anything because you
Um,
are doing not
I
much?
yes, I'm getting to what you want to say. I have never thought about it, but yes, what you are saying, there is a point in it that the 4x magnification that the robotic platform
Yeah,
offers, definitely it will be
yeah,
useful in infants, because anyhow, whenever you are doing open, you always use the loops. So
yeah,
here,
yeah,
anyhow,
yeah.
it is
Same
going to
like
be
that.
an 4x thing. So the part of the
Yeah.
spatulation that you are seeing, actually,
Yes,
that was
yes.
actually 4x was benefiting in that.
Yeah. Otherwise, that was very difficult. The I don't know how the Caesar comes. If the Caesar is big in laparoscopy, we cannot do that. We will take three French. I don't know how in robotic same Caesar is used for all the thing because ureter will be very thin lumen.
I think the
Uh,
dexterity is the key. The stableness,
Key there.
absolute stableness that was there.
Yeah, you have shown that in that 3 months. That was very narrow ureter and it's spatulated, and you have cut the redundant pelvis also at the because the dexterity and able to hold precisely wherever you want. Great. So I appreciate, sir. My knowledge regarding robotic technology is limited, almost nil, but I am able to see and understand what it is a little better because I am interviewing you, and I really appreciate that you have chosen this rare field. Hope you will excel in this. I didn't know that your MS boss is also pediatric surgeon and you have gone for fellowship for pediatric urology. Let's hope in pediatric robotics you will do the transplant as well as advanced surgeries like partial nephrectomy for anything tumors and come out with much more experience. Thank you very much for giving this
Thank
time,
you.
sir.
Thank you. Thank you
Thank you
very
very
much,
much,
Dr. Chandramohan.
sir.
Thank you. It's a
Thank you,
pleasure.
sir. Thank you very much.